Hey guys, Mike with FlightBridgeED. I've been an EMS training officer since 2008, and I don't know how many times I've had to deliver the bad news to someone about an expired certification. That means no work. That's where Piace comes in to save the day. Never be caught off guard again with an expired cert. Go to the App Store for your device and search for Piace, P-I-A-C-E-T, the one-stop application to manage and share all of your certifications. You know you don't want to be that guy or gal, and don't rely on your agency to tell you about your certifications. Go to Piace to manage your own certs and have some peace of mind. Download Piace today.
The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
So the next speaker coming up is someone I've known since I was like 13 years old. So Sam Ireland and I grew up together. We've been friends ever since we were ever even in medicine. And he is my partner. He is the co-creator of Foam Frat. And we created a blog and podcast. And, you know, like, I feel like I get a lot of the attention for Foam Frat and our blog and our podcast and a lot of stuff we do because he's not as, like, out there on social media. But this guy is brilliant. He's one of the people that have inspired me to continuously try to improve myself. And you guys, he's actually going to start podcasting on Foam Frat this year, so you're going to start hearing a lot more of him. But Sam's going to come up, and he's going to talk about traumatic arrest. He is hands down one of the best speakers I've ever seen, so you got to live up to that, man. Let's give it up for Sam Ireland.
Don't you hate it when somebody builds you up and you got to get in front of a bunch of people and live up to it? So today we're going to be talking about traumatic arrest, and more specifically, critical thinking inside of traumatic arrest. And I'm going to tell you a story. And this is a true story, and it's going to be kind of woven in and out of this talk for the next 20 minutes. If you pay attention, somebody from these parts told me, hey, you might have to tell people what the tree stand is, but you guys hunt down here, right? You go out for people, fall out of tree stands and stuff. So that's what we're looking at here. And so you're on a ground unit, and you get called out for a 5-year-old male, and your dispatch information is that this guy fell, and now the family is reporting that he has trouble breathing. Okay, so you're en route and you and your partner are talking about it, and you get out to this property, okay? And it's a huge property. You don't know it now, but it's pretty big, and you're about to find out why. So you pull up to the front of the house, and there's 2 ATVs waiting there with some kids on them. And you pull up, and they say, yeah, Dad's in the back. He's in the back of the woods. We got to take you through the trails to him. That's the only way to get to him. You're not going to be able to fit the ambulance back there. So you're like, all right. So you grab your trauma bag, you grab the airway bag, you grab your score suction, you grab your decanter catheter, you got the monitor, you're loading up all this stuff, and you jump on the ATVs with a couple of kids. And you are going back and you're asking them, so what happened to your dad? What happened today? Why did you guys call? Well, he was up there putting the tree stand up, and he goes ahead and he falls, and he fell on his side. And he was super short of breath. We had no reception back there, so we had to ride back up to the house, call 911, and we waited for you guys. How did he look when you left him? He was really short of breath. Okay. You get back, you look at the tree stand, you look at the guy laying on the ground right there, and it looks like about a 15-foot fall. And it's not quite 3 times your height, you're estimating it. He fell from a ways. Kids said he fell right on his side. And so Dad is not looking very good right now. And so you go up to him and you lay him supine. He didn't respond to any painful stimulus. And so what's the next step? You go ahead and check for a pulse. And what do you think you feel? Absolutely nothing. So the kids are sitting there watching you, and you instruct your partner to go ahead and start CPR on that patient. Scary, right? Middle of the woods, not a lot of help, just you two. And so what now? You expose the chest, you go ahead and put pads on this guy, and sure enough, what do you find? The guy's in PEA. Very interesting. We'll come back to that call in just a second. So whenever we feel a patient's carotid artery, and we're putting our finger on it, and we're feeling, God, has it been 10 seconds yet? Come on, a pulse. No pulse. It's almost like somebody reaches inside of our ear, and they reach all the way up to our brain, and they start playing this DVD. And unfortunately, it's an AHA DVD. And we all know which one it is. We've watched it many, many times, right? And it takes over so much room inside of our brain that it kind of shrinks our cognitive function down inside that little part you can put your finger in, right? And this plays over and over and over again. And sometimes it takes over our critical thinking. If I gave you guys, every single one of you in the room, I'll bet you there's a ton of instructors in the room, people who know ACLS backwards and forwards. You probably have had dreams about it when you first certified. If I gave you a blank piece of paper, I bet you could write this algorithm out from memory, just from what's inside your head, right? Here's what happened on this call, though, is when we get a patient that we can't shock and give antiarrhythmics to, we don't have an immediately reversible cause, sometimes we start blocking out a lot of that other stuff, and we just get set in this loop right here. And people say, well, hey, if the person's not in a shockable rhythm, hey, that gets really easy then, right? To start doing chest compressions, go ahead and push the epi, maybe get an intubation out of it, and you just keep doing that and doing that and doing that and doing that and doing that until the patient expires, right? Well, I've got a sad story to tell you. That story, that with the kids watching you resuscitate, this is exactly what happened, and the guy died. No reversible cause, was treated by the paramedics. It's a sad story, right? If you were to draw that algorithm, like I said, and you go ahead and you take that blank piece of paper, would you be able to draw this one? There's this little box, this little unexciting looking gray box on the very bottom right-hand side of that algorithm, and it's the reversible causes. So this actually has some good stuff in it. So which ones apply to our traumatic arrest patients? Hypovolemia for sure, right? If the patient doesn't maybe bleed out internally, we have external bleeding, right? Or maybe even relative hypovolemia. If the patient had like a transected cord or something like that, definitely plays into our plans to resuscitate these patients, right? Hypoxia, you think that guy was hypoxic before he coded? Oh, God, yeah. Progressive shortness of breath, unresponsive, pulseless PEA now. Whew, yeah, I bet you some hypoxia definitely played into that, right? Tension pneumothorax. Was tension pneumothorax like screaming in your brains as I was telling you that story? That's good, because that doesn't occur to everybody. Cardiac tamponade. We normally think about that a little bit more when we think about the penetrating trauma. Somebody got shot, somebody got stabbed. But is that something that we have to rule out inside of cardiac arrest with a traumatic cause, PEA? Yeah, absolutely. So there's this thing called hot arrest. And for some of you, you already know what I'm talking about. Some of you might not know it has an acronym. But I guarantee that if you already know where I'm going with this, there's somebody at your service who doesn't or wouldn't know where I'm going with this, and they need you to help them learn, because this is still an issue in EMS today. This following transition is my attempt at making a joke. Arrest is so hot right now. Thank you, I'm just kidding. So, the HOT protocol, it stands for hypovolemia, oxygen, tension pneumothorax, and cardiac tamponade. And I do have to give a little bit of a shout out to the ERcast podcast, because Rob Orman, Anand Swaminathan, and Scott Weingart, they kind of threw that extra T on the end of there when they were talking about this. So this is something that's been around for a while. Even Eric did a podcast back in 2013 on reversible causes of traumatic arrest. So this is a conversation, but how integrated is it into your systems right now? So we'll talk about hypovolemia first. And so mostly this means fix the bleed. This is like the most controversial one that we're going to talk about, because this has a lot of different aspects to it, because hypovolemia plays such a key role in traumatic arrest. The first thing is obvious. If they have a bunch of internal or external bleeding, you better have tourniquets ready. Does it make any sense to do chest compressions on somebody who, first of all, has no volume to circulate, and second of all, is just going to bleed out of the hole that you didn't cover? That does not make a lot of sense, right? If they got an amputated arm and every time you do a chest compression there's blood leaking out of that arm, you're just chasing your tail, and that is not a resuscitation that's going to go very well, right? High and tight tourniquets, high and tight tourniquets, high and tight tourniquets. Pelvic binding is another one. If you suspect there's severe pelvic trauma, don't pay attention to the background, but the foreground with the pelvic binder is the reason I put that picture on there. Binding the pelvis can be a very, very life-saving maneuver. Another case for high and tight tourniquets, right here. You have a patient with bilateral femoral fractures. Why is it worse if they go outside, or why is it worse if the fractures go inside rather than outside? Somebody say the arteries? Yeah, when you look at where the femoral arteries lay, that's a dangerous spot for those sharp fragments of bone to be, right? High and tight tourniquets. And if there is trunk bleeding, trying to address it the best you can with as many hands as you have. Try to prioritize and use critical thinking. Here's the one. This is the one right here. We have learned so much about fluids and there's been some really, really great information. So let's break this down. Inside traumatic arrest, I'm talking about a person who is not generating a pulse at this time, okay? What happens when we give fluids? Let's say we give blood. Blood makes sense, that's kind of an easy one. Do we carry enough to actually make a difference? I don't know the answer to that question in every patient. But did they lose blood and you put blood back in? Seems like a pretty uncomplicated thing, right? But what about the other stuff that we infuse into people? The clear stuff, the stuff that's super acidic. Well, that's one of the problems with it. You choose to infuse saline into that person, you are going to make them very, very acidic if you choose to use normal saline. What else are you doing? You're taking the platelets that are inside there that were this close together, and what's happening as you give more and more fluid? They're drifting further and further apart, making it more difficult for them to form a clot. And you're also thinning the blood so that any clot that they have formed so far, it's much easier for blood to sneak by that clot. Deleterious things can happen for sure. More bleeding, bleeding through clots, harder to form clots, acidosis. Now that we've got those out of the way, what about the patient that has, like I said, they're not generating a pulse anymore? Are they ever going to come back if they don't have enough volume to circulate? If they physically do not have the volume to circulate? You cannot have cardiac output without volume. Use your critical thinking ability in these traumatic arrests. If you have somebody that's arresting in front of you or has arrested in front of you, do they need volume? They're not going to survive without volume. Are there deleterious effects? Yes. Should you probably stop any active bleeding before you try to give any kind of saline or LR? Yeah, absolutely. Be smart with your fluid resuscitation. So the second one, know when they are not viable patients. Some patients, when we talk about these hot arrests, this isn't for everybody. There are some injuries that are too serious to be resuscitated with this protocol. So oxygen, this one's really simple, right? Raise the PO2, raise the partial pressure of the oxygen coming to the patient. So when I first told you about that scenario, kind of coming back to our call, remember what they did first? They checked for responsiveness, and then what do they do right afterwards? Checked a pulse, started CPR, right? You might be thinking, well, Sam, everybody's saying that closed chest compressions do absolutely nothing in the traumatic patient. Yeah, you are absolutely right. It does nothing for the traumatic arrest patient. There's either not enough volume to circulate or it's forms of obstructive shock, right? What are closed chest compressions going to do? But let me ask you this question. Were you 100% sure, let's say you were one of those providers, that was a traumatic arrest patient? What if he had a cardiac history his sons didn't know about? Guy goes up to go into VTAC with a pulse up on that tree stand, falls, didn't actually suffer an injury, and while you're putting 2 holes in the side of his chest, he's actually waiting for you to defibrillate the VFib that he's in. Yikes. Do CPR first, but then quickly realize, is that a traumatic arrest? PEA, stop CCR at that time, and then worry about the oxygenation aspect. Now there's 2 schools of thought on this. Should you just go for a supraglottic airway right away? Or on the other hand, should you be putting an endotracheal tube in? Very interesting. Where I work, we have hyperangulated VL, and they perform suction right away, the salad technique. They can pretty much get an endotracheal tube in as fast as somebody can put a supraglottic airway in. So that is personally what we choose to do. On the other hand, if you have a BLS provider managing the airway, maybe it would be quicker, more effective for them to put something like an LMA in, something without huge balloons in it that's going to prevent blood flow to and from the brain, something like maybe an eye gel if you carry those. Maybe that would be a good temporizing measure. And if you can't get an airway either one of those ways, what are you going to do? Somebody say it. Yeah, you got to cut the neck then, right? Don't call a code without a definitive airway. The next one is tension pneumothorax. And like I said, when I was telling you guys that scenario, hopefully in your head you were thinking, the next thing he's going to tell me is that they decompressed the guy, he got a pulse back, and he hugged his kids. That was not what happened, but that's what should have happened, right? So pop the lungs. That's where this comes from. And why? Why is this so high up on our priority list? Because when those inferior and superior vena cava, already a low-pressure system, when they get clamped off, there's no blood flow coming into the heart. And it's as simple as this. Preload is a prerequisite. That's a good way to think about it. Preload is a prerequisite. Well, to what? To cardiac output. That is literally the volume coming back in so that it can get pumped back out. And if you don't have anything coming in, what are you pumping out with your chest compressions? When you are doing those chest compressions, and you're on the patient, and you lift your hands up, and you're allowing full chest recoil, just like you're supposed to do, that's great that you're doing your part, but physiologically, the patient's body is not doing their part, and that's why the chest compressions don't work. So remember that what doesn't come in cannot go out. So when you see a lung like this, remember your sights for decompression. Needles are generally faster than putting a finger through the chest wall, but needles have a high rate of failure. So even if your impression generally is, like if you went on that call and you darted that guy and you weren't getting anything back, and you didn't hear that when you put the needle into the chest, and you're thinking, this has got to be a tension pneumothorax. And it doesn't work the first time. Maybe you got to do it a second time. Maybe you got to do 2 on each side and then do fingers through the chest to make sure. Make sure you're taking care of that reversible cause. A finger through the chest is much better at evacuating blood and evacuating air than a needle is. How about the last one? How about cardiac tamponade? Like I said, we generally think about this when we think about penetrating trauma. A knife comes in, something lacked the heart, right? But we need to free the heart. I love this new website that I'm looking at. Have you guys seen this? Medcomic.com. It's full of a bunch of illustrations, and they are so simple. The most complicated subject, they make a funny cartoon out of it, and you will never forget the picture. And so I love this one. Look at this guy up here. His guy's face cracks me up. So he's the venous side, right? Why is he looking like that? Like he's about to Ralph. He's looking like that because no blood can flow back into the heart, right? He's all congested back there. Nothing can get back in to get pumped out. Over here, you got the sad arterial guy looking like he just got knocked out in a fight, right? Because there's no flow coming through him at all. There's no cardiac output. And then you got the heart right here in the middle being squeezed on, being squeezed. Nothing we do with our chest compressions is doing anything because he's got this big sack of blood around him, right? Is it any wonder why a heart that looks like this is not generating a pulse? And are your chest compressions going to do anything for that patient? Preload is a prerequisite. You need the blood to flow in so that it can flow out. And what doesn't come in cannot go out. I cannot drive that point home enough. So you have to perform that pericardial centesis to rule out that form of shock. Same side of the xiphoid process as the heart, aim towards the ipsilateral shoulder blade, 45-degree angle towards the scapula. This shouldn't be something that medics say at the end of their career, yeah, I did a couple of those, or I never did one of those. It should be every traumatic arrest before you call that patient. It shouldn't be that last-ditch effort. It should be within those first few minutes to make sure you're not missing something if that's your impression. So when you guys go on a traumatic arrest, I want you to picture the following picture, okay? This is what should pop into your head. This should be you on your way to a traumatic arrest. Why this picture? Because it's kind of weird, first of all. And I'll tell you why else. Because the take-home message is grab all the sharp stuff. If you cannot get an airway, you're going to cut an airway. If your patient arrested for a traumatic reason, then you're going to put holes in the chest. And if that patient had penetrating trauma, or after you put those holes in the chest, you're going to get the long, sharp thing, and you're going to go towards the heart with it. And then you're going to drill an IO, and you're going to take care of the bleeding. It's all of these invasive procedures in order, boom, 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 one right after the other. So when you look at this algorithm, look at it a little bit differently when you think about trauma. Think about all this stuff over here being useless in trauma, and think about all this stuff down here being life-saving in trauma. Pay attention to that unexciting little gray box at the bottom right-hand side. This is probably how that call should have went. Start CCR, confirm a non-shockable rhythm. They are in a non-shockable rhythm, it's PEA, traumatic arrest. All right, stop CPR. We got a few things to take care of first. You go ahead and intubate the patient, do salad if you need to. I'm gonna come over here. I'm pretty sure this is a tension pneumothorax. I'm gonna do that first. If we don't see return of spontaneous circulation right then, I'm gonna do a pericardial centesis. And then I think we're gonna drill an IO and maybe get some preload in here. I don't see any obvious bleeds, but we might need a tourniquet if he fell on his femur or something. I'm gonna do a once over real quick. Let's get this done within the next few minutes. Let's try to find these reversible causes. So please, don't send any of your traumatic arrest patients to the morgue when there is an easily reversible cause of that traumatic arrest. Thank you, guys.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.